Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
For today's episode, I'm presenting a lecture that I gave for the Izmir Online Neurosurgery group in the country of Turkey. In this presentation, I discussed some of the nuances in Tarsal Tunnel Syndrome and also presented them with some interesting facts and information about the Phoenix sign. So I think you'll find this episode very beneficial, especially if you watch it in the video format versus the audio format. So please enjoy this rebroadcast of Tarsal Tunnel Syndrome and the Phoenix sign. So we're going to talk about two things today, Tarsal Tunnel Syndrome and the Phoenix sign, and I'm excited to be able to present to you on both of these topics. Let's start off with Tarsal Tunnel Syndrome. What is it really? That's a great question because the nomenclature is somewhat wrong because it's really more than the tarsal tunnel. As we can see in this illustration here, we have the tunnel that we're looking down, and then we have the two smaller tunnels, the medial plantar nerve tunnel and the lateral plantar nerve tunnel. And let me go back to that. And so where this compression really is in four areas, and we're going to delineate that a little bit. But tarsal tunnel is a relatively new syndrome, if you want to categorize it by when it was named. Of course, this has existed probably since man started walking, but it was first described by Lamb in 1962 and then was followed up with Keck in the same year, where he also successfully treated cases with nerve decompression. If you look at the early literature, it's really quite disappointing. We can see here from 1970 to 1996, you had 0%, 15%, 20%, 24, 26, and 54% in just some selected articles during that time period, which had an excellent result. Now, if you think about that, having a 0% or even a 54% excellent result is really not that excellent, in my opinion. And when you're treating a lot of patients, you don't want to have a failure of this high. So we have to ask our question, why are the outcomes so poor in the early literature? And I think it can be summed up in these five bullet points. One is that at the time when they were first looking at this, they were only releasing the flexor retinaculum or the laciniate ligament. And we know that the compression is happening in more than that area. When you look at these articles, a lot of times they have very long periods of immobilization. And for some reason, there are still pockets within the world that will do a tarsal tunnel decompression and then place the patient in a cast for 4 to 6 weeks, and they won't get any benefit because it scars right back down. And so you need to move these patients immediately after surgery so that nerve can slide and glide just like a tendon would. Unrecognized proximal entrapments are likely why some of these success rates were so low initially. We know that just like in the upper extremity with the carpal tunnel and more proximal median nerve entrapment, we can see the same thing in the lower extremity. I'm going to touch on that a little bit more later in the talk. Another idea or reason that these outcomes were so poor is because of comorbidities. And if you don't address the comorbidities really in any condition, your likelihood for success will be minimized somewhat. And then tarsal tunnel has some very interesting nuances when it comes to biomechanical aberrations that contribute to this condition and exacerbate it. So we'll talk about those as well. So what is the pathophysiology of tarsal tunnel syndrome? Well, it's much more complex than most people think. My son Kyle is a mathematician and a mechanical engineer, and I was talking to him one day when he was in graduate school, and I said, I've got this idea that there are a lot of things that go on that can affect why a person will have tarsal tunnel syndrome, or even why it's more severe in one person than the other. And so I gave him some things that we classically look for, such as the biomechanical position, whether or not the patient has a metabolic condition, such as type 2 diabetes, these types of things. And I said, if you took all these 5 or 6 variables that I had and you mathematically put them together, how many different combinations could you come out with? And he came back in about 5 minutes and said, a little over 184,000 different combinations of events that could lead to this. And that's probably, truthfully, on the low side when you really start thinking about this. So a lot of times we get to the point where we just kind of want to bury our heads in the sand because there are so many things going on with this. And that's what makes tarsal tunnel syndrome such a complex thing. And actually, in my opinion, makes it a much more difficult nerve entrapment to treat than many other nerve entrapments, because of all of the things that are going on that can contribute to the symptomatology in these patients. So some of the things that we look at obviously are, is there some space occupying lesion like a ganglion cyst? Is there some aberration in their foot type, whether they have an extremely flat or pes planus foot or a high arch pes cavus foot? High BMI, do they have equinus? Was there some trauma? These are all things that have to be taken into consideration to get a full grasp of what your patient is suffering with this condition. So my mentor, Lee Dellon, who is a retired professor of plastic and neurosurgery at Johns Hopkins, eloquently pointed out that tarsal tunnel is really a 4-tunnel entrapment. So we can see in this diagram, classically, everyone thinks of the posterior tibial nerve as being entrapped in the flexor retinaculum or the laciniate ligament, and that's the site of the compression. Well, we know that that really is the least compressive area of the 4 tunnels that we deal with, and the other tunnels are the medial plantar nerve tunnel, the lateral plantar nerve tunnel, and that gives you the distribution of the sensation on the plantar aspect of the foot. And then we have one small little tunnel or 2. Sometimes patients will have more than 1 medial calcaneal nerve. In fact, most of the time they have 2 medial calcaneal nerves. But to that extent, those are defined, well-delineated anatomic tunnels as well. So we have to think of tarsal tunnel syndrome or tarsal tunnel as a 4-tunnel compression situation. If not, you're gonna be doomed to failure. Now, this diagram, if you look at it too closely, might get you going in circles. But let's take a look at the 2 photos that we have of the foot. Now, this would be a foot in what we call neutral position, and this is a foot that is collapsing. In this case, it's a left foot, and you can see that this is a severely pronated foot. Now, we know that pressures will change inside these tunnels of the tarsal tunnel based on position of the foot type, as well as other things. So if there's some type of compressive situation where you have a schwannoma or some type of an intraosseous, or an intraneural ganglion, that certainly can lead to the symptomatology that you're going to see and the effect on the peripheral nerve. We have a clear association with type 2 diabetes and nerve compression. I'll talk about that in just a little bit. So all of these things feed each other. And then we know that when we have a compressive nerve situation, then that feeds back and gives us changes at the systemic level. So there are a lot of things that are going on in this particular area of anatomy that really can lead to not only difficulty in trying to figure out what's going on, but lead to the condition itself. So this is another illustration, and we can see that down in the portopetus. So this would be the medial plantar nerve artery, lateral plantar nerve artery, medial plantar vein, lateral vein, and then your 2 yellow circles here would be the nerves themselves. And as you can see that when this foot goes from a neutral position into a pronated position, as we see over here, you're going to get compression, a direct mechanical compression on this nerve. So when you think about that, what's going on with this foot type, what's going on with this patient? Are they high BMI? Do they have type 2 diabetes? These types of metabolic things, you can see how they add up very quickly and basically can lead to the problem. Now, my colleagues in Madrid, Dr. Iborra and Dr. Villanueva, have published some beautiful work. And what they did in this study is they actually looked at the pressures within the different tunnels, the medial plantar, lateral plantar, and the tarsal tunnel itself. And this is their data. So when we look at this, it's very interesting. When you think about the tarsal tunnel, you got to think about retinaculum. What is the flexor retinaculum? How much pressure is going on in this space? This is that area just medial to the medial malleolus, or posterior medial to the medial malleolus. And you can see the pressures in here in their initial subset of patients. And when you compare that pressure to the pressures that they saw in the medial plantar nerve tunnel, and these are all in millimeters of mercury of pressure, you can see 89 versus 46. So it's nearly twice the pressure in the medial plantar nerve tunnel and more than twice in the lateral plantar nerve tunnel. So you can go down and you can pretty much look at all of these, and they're consistent in the fact that the pressure is lowest in the tarsal tunnel area under the flexor retinaculum or the laciniate ligament. It's always higher in the medial and lateral plantar nerves. And those I'm going to delineate out a little bit more for you anatomically in just a minute. I think the take-home message then, and you all as neurosurgeons know this, is that, you know, any pressure above 20 millimeters of mercury to 30 millimeters of mercury can impair intraneural blood flow. And this is clearly what we see in the periphery. And then when you look at different positions here, a neutral subtalar joint position is essentially a neutral position of the foot. It's not supinated and it's not pronated. And in that situation, those are where you find your lowest pressures. In a maximally pronated foot, this particular study showed about 32 millimeters of mercury. Well, we see that much higher. The other thing that this slide doesn't show is what happens in supination. Now, in supination, with an inversion of the foot, you would think that because the strain and the pull on the medial lateral plantar nerves and the tibial nerve itself are in actually a more relaxed position, that you would have a decrease in tunnel pressure. But in fact, it turns out that there's an increase in the pressure. Now, there clearly is a decrease in the strain of the nerve with that position. So if we have to think about this in a simplistic way, supination and pronation are occurring every step that you take. And every step that you take, those pressures will increase with those two movements, either in pronation or supination. So now, if we pronate and we visualize that foot collapsing, you can see how that's going to increase the strain or the tension on the posterior tibial nerve itself. And we know that about an 8% increase in strain or tension will cause a venular flow obstruction, and a 15% increase in strain or tension will completely occlude arterial perfusion in the vasa navarum. So this is kind of an interesting thing. The other interesting thing is that you can actually see changes in amplitude of your action potential with just 6% strain, and then a complete conduction block at 12%. So it doesn't take a significant amount of mechanical activity to affect this nerve directly, as we can see here. Now, a lot of times people, I guess there's two types of people in the world. There's the group that accepts that tarsal tunnel exists, and there's the group that doesn't accept that it exists. There are people that believe that it doesn't, it's just not a clinical syndrome, which I think is, rather unfortunate. But if you think about when we're diagnosing tarsal tunnel syndrome, first, it's a clinical diagnosis. But you have to think about this, is tarsal tunnel syndrome a symptom? Because you have all of these other things going on. So it could be both a symptom, which I think it is, and a syndrome. So you always want to treat a symptom when you can know what the pathogenesis is for that patient. So how do we diagnose it? Well, very, very important with any neurological condition is just taking some time to listen to what the patient will tell you. So the history of present illness a lot of times can give you some great insight into what's really going on. For example, they can't tolerate a shoe that has any insert in it or any arch support. Well, empirically, you would think that because there's more pressure in the arch and that's where these nerves are trying to go through in the portopetus, that would make a lot of sense. So when you listen to them and they'll tell you these things, it adds up. The other two clinical signs that we look for is a Tunnel sign and a provocation sign. I'm going to show you a video in just a second that will delineate that a little bit more. And then we also want to think about what else is going on. Do they have a metabolic syndrome? We know that diabetic peripheral nerve causes intraneural edema because of the way the polyol pathway is affected. And then we can ultimately figure out the differences in the nuances of a particular tarsal tunnel syndrome with peripheral nerve blocks. And we'll talk about that in just a little bit more. Additional things that can be done to help you with your diagnosis is obviously electrodiagnostic studies. We've kind of found that nerve conduction velocity EMGs in the lower extremity for this are usually about 50% of the time really don't give us anything. They're either false negative. Most often they're false negative. And then the other test that we use is called a PSSD test. That stands for pressure specified sensory device. It's simply a computerized interpretation of 1-point and 2-point discrimination. And it's a very good way to figure things out, much more eloquent than a Semmes-Weinstein monofilament. MRIs are useful if we think there is a space-occupying lesion. However, in our practice, we find diagnostic ultrasound much better because with diagnostic ultrasound, what we're able to do is eliminate or confirm the possibility of a space-occupying lesion very easily. The second thing is that we can put it in the vascular color flow mode, and we can track down the medial plantar artery and the lateral plantar artery, and we're able to see a significant, in very tight tarsal tunnels that are very symptomatic, we'll see basically where the arterial flow just stops because it's so compressed in that area. And that gives us a little bit of an insight into how much nerve compression is going on. If there's enough pressure to compress a small artery, there's certainly enough pressure to cause some of these pathophysiologic changes that we've talked about on the nerve itself. And then you need to really look at the global presentation of the lower extremity. If you have somebody that has almost like a club foot or some severe orthopedic presentation that's just putting this nerve under too much tension, decompressing that nerve is not going to do anything unless you actually address that orthopedic deformity. So many times we'll actually treat tarsal tunnel without treating the tarsal tunnel itself, and I'll talk to you about that a little bit. And then finally, one of the things that really needs to be in the top of your mind when you're looking at these folks is to evaluate what's going on with the proximal tibial nerve. We know that the tibial nerve, after it bifurcates up in the lower 1/3 of the thigh from the sciatic, we know that as the tibial nerve transverse goes down distally at the level of the soleal sling, it can be entrapped. And then also at the distal medial gastrocnemius soleus junction, where it's coming from the deep posterior compartment to the subcutaneous space. So we'll show that in just a little bit. We also like to look at a couple of other things. Motor strength, obviously. In later stages, you'll see a decrease in strength of the intrinsic muscles themselves. Do they have equinus? If they have a limitation of dorsiflexion, that's going to change the pressure in their tunnels tremendously. Do they have something that's completely outside of the tarsal tunnel that's causing the tarsal tunnel? And a lot of times people really kind of just focus in on this medial ankle, but what happens if there is a Morton's entrapment out in the forefoot? Well, people compensate for things. If they have a lesion in the skin underneath a metatarsal head, something as simple as a porokeratosis, it may change their gait enough that alters the pressure within the tarsal tunnels themselves. So these are things that we have to think about in addition to, okay, is it a nerve entrapment? Well, if it's a nerve entrapment, then all of these other things have to be taken into consideration so that we can kind of figure out are we going to be successful treating it, and how we really need to treat it. So I want to just play this video for you.
Okay, we're going to just show you a physical examination for tarsal tunnel syndrome. Don't really like calling it tarsal tunnel syndrome because it's bad nomenclature. We all know that really the entrapment occurs more distal to the flexor retinaculum, the synovial ligament in this area beneath the deep fascia to the adductor hallucis muscle. So we look at two things, Tunnel's sign and provocation sign. So when you start with both, for Tunnel's example, we'd start tapping lightly along the nerve and ask the patient if they feel any radiation, electrical, tingling type sensations. For provocation sign, we want to start up here proximally at the area of the distal gastrocnemius soleus junction. We know that the nerve exits in this area from the deep posterior compartment, and you'll just simply palpate along this area and ask the patient to tell you if they feel any significant tenderness. And of course, you'll check the contralateral foot, and they'll be able to tell a difference. You may have to go back from one foot to the other. This way, you're able to isolate if the entrapment's medial plantar nerve, lateral plantar nerve, or more proximally in the tarsal tunnel itself, or even more likely a proximal tibial nerve entrapment. So it's pretty easy, combined with a history of present illness, to diagnose tarsal tunnel syndrome. Okay.
So Dr. Dillon also made a very astute observation that there's a very high association of people who have had failed Morton's neurectomy procedures and as high as a 54% incidence of tarsal tunnel. So the question begs here is, which came first, the chicken or the egg? Was the tarsal tunnel the subsequent problem because the patient was altering their gait because of an entrapment of the nerve in their forefoot? Or was it always an entrapment of the tarsal tunnel that was leading to the symptoms out more distally towards the toes? So that's a great question. But when you see somebody that's had a neurectomy or some type of a procedure for a Morton's, and they also have continued pain, you have to think about the tarsal tunnel, because a lot of times it is associated, or sometimes it's the driver itself of the tarsal tunnel. Now, based on my clinical experience over the last 37 years, is that there's a very high association between heel pain and tarsal tunnel syndrome. And if you think about it, there's so many interrelated mechanical things that are going on in the lower extremity, and particularly the foot itself, that if you have something like a plantar fasciopathy or plantar fasciosis, it can lead to a change in the gait. It can also lead to a direct entrapment of the medial calcaneal nerve. And this has been published. There hasn't been a lot published in this area, but you can see the citing for these two articles that there is a direct association between plantar fascia and medial calcaneal nerve entrapment, as well as tarsal tunnel. So I would say, in my experience, tarsal tunnel probably after plantar fasciopathy, tarsal tunnel would be right up there in the top 3 or top 4 of the things that are going on when somebody initially presents with with heel pain. So a lot of times these patients will come into the office with heel pain, and what's the default mode of examination? Well, you press on their medial calcaneal tubercle right here, as we can see, and then if the patient says, well, that hurts, then a diagnosis of plantar fasciitis is made. And that may or may not be the case, because I'll tell you right now, my thumb isn't that good, and most people's thumbs are not that good, but we're going to see what is really good in just a second. But before I jump to the next slide, realize that, okay, if I have a medial calcaneal nerve pain in this area due to plantar fascia, look where the lateral plantar nerve tunnel would be. It's right in that area. So it's really hard to differentiate these things sometimes. And the best way to differentiate it is with sonography. And in this sonogram, we're looking at over here, this is the medial calcaneal tubercle. The skin is here, dermis is right there. And then this is the subcutaneous fat, or the infracalcaneal fat pad. Great signal intensity here, perfect signal intensity here, and perfect measurement. We know that if we evaluate the plantar fascia based on thickness as well as its signal intensity, we can be very accurate whether or not they truly have plantar fasciopathy. And this is a perfect plantar fascia. This could be put in the textbook of what is absolutely normal. And if we put it next to a fascia that is abnormal, you can see even non-radiologists such as myself and the patients will be able to tell this is a pretty sick fascia compared to this fascia here. Now, this a lot of times will present primarily with tarsal tunnel symptomatology versus direct frank heel pain, or a lot of times they'll have both. And because they have both, we named this about 25 years ago, multiple etiology heel pain syndrome. That's a big word, so we just call it MEPS. But you can see in the Venn diagram here, if you have plantar fasciopathy and you have something going on with the nerve, there's clearly an overlap where they can have both things at the same time. And then that just keeps feeding the fuel on the fire, because then they have a lot of difficulty. So we developed this questionnaire. It is not scientifically validated. I would love for it to be validated sometimes, but it's pretty darn accurate clinically. And we're able to tell, based on these symptoms, that the patient relates what their likelihood is for having both or strictly nerve. One of the key things here is if they tell you that they've had an orthotic device and it actually made their heel pain worse, it's almost pathognomonic that it is a tarsal tunnel syndrome or a nerve entrapment. So this is a very interesting thing. If you only ask the patient one thing, and that is, if someone's made you an orthotic for your heel pain or your tarsal tunnel, did it make it better or worse? And 99% of the time, it's going to be, oh, it made it worse. I couldn't tolerate it very, very much at all. Well, that's very diagnostic for tarsal tunnel syndrome. So decision-making can be pretty complex in tarsal tunnel syndrome, as we've already pointed out. But if you have a situation where there is some alteration of the plantar fascia in conjunction with the presentation of tarsal tunnel, always treat the fascia first, because it's much easier to treat that condition. And then many times, maybe 50% of the time or not, you don't have to treat the tarsal tunnel. It just gets better once the fascia gets taken care of. So that's kind of what we want to think about when you have somebody with tarsal tunnel. Really kind of focus in, do they have some component of heel pain as well? Now, diagnostic blocks have been huge for us because they allow us to do a lot and to differentiate where anatomical entrapment is presented. And so if I give an injection up here, so if I put a bunch of lidocaine in this area, it doesn't tell me anything if that patient's pain goes away, because I've knocked out the entire posterior tibial nerve, medial plantar nerve, lateral plantar nerve. Now, there's one more entrapment that's right up in this part of the foot that we're just now becoming a little bit more aware of, let's say in the last 4, 5, 6 years, and that is the distal medial plantar nerve as well. So it can be another branch. Usually it comes off of the medial plantar nerve, but sometimes it can even be a branch off the saphenous nerve. So it can kind of trick people up just a little bit. But if I'm able to put in a few tenths of a cc of lidocaine on the medial plantar nerve and all their pain goes away, then I know most of their stuff's coming from medial plantar nerve versus lateral plantar nerve. And so I'm able to kind of delineate it a little bit more. And then if we wanted to evaluate the medial calcaneal nerves, we would just come down in this area here. So by discrete small amounts of lidocaine in these areas, we're able to map out exactly what's going on for these patients when they present with compressive symptomatology. So if we look at this, this was what I was alluding to a little bit before. Here we can see our sciatic nerve coming down. It divides into a common peroneal branch and the tibial branch. And as the tibial branch descends distally, where it comes in underneath the soleus, it has an arc of tissue called the soleal sling. This is in some people, it's very tense, very dense. In fact, when we're doing some decompressions in this area and people that are very symptomatic, you'll put your finger in there and have your assistant dorsiflex the foot, and it almost feels like somebody's trying to chop off the end of your finger. That's how intense of compression this structure can give. And a great way to diagnose this is to simply have the patient stand up against the wall, raise up their leg that is non-symptomatic, and have them do some toe raises, usually 10. Hold it on have them hold in a toe raise on the 10th, and then press in this area right here. and they will not like that very much. It's a very powerful provocation sign. The other place for proximal nerve entrapment of the tibial nerve is at, as we mentioned, where it comes from the deep posterior compartment into the subcutaneous space. And this would be proximal to your tarsal tunnel, maybe 4 or 5 inches. So those are the areas where you want to make sure. Now, one thing, if you have, and this is a great take-home point right now, if you have a situation where the patient initially presents with tarsal tunnel syndrome and they also have overwhelming proximal entrapments, most of the time we will decompress either of these or both of these and leave the tarsal tunnel alone, because if they have this, they're more than likely going to get better in their tarsal tunnel. And these areas proximally are a lot easier to heal, and they have less biomechanical things going on in that area. So we always take care of the proximal entrapments first if we've determined that the patient is suffering from a proximal nerve entrapment. So what about management of tarsal tunnel? Well, I like conservative management of tarsal tunnel because of the fact that so many things are going on, but sometimes you just have to go into the surgical arena. Now, previously, there was nothing between conservative and surgical, but now we have peripheral nerve stimulation that has become more and more used in our practice in situations where we just feel a patient might not be a great surgical candidate. Maybe they have a lot of venous stasis, maybe they have trophic skin changes distally, so we can come proximally and do a small incision on the proximal tibial nerve and put in a peripheral nerve stimulator, and that works very well in many cases. So it gives us a little bit. Now let's talk about conservative care. So a lot of times these patients, by the time they see us, they're pretty far down the line, but a lot of them have been put on gabapentin or pregabalin, some type of neuromodulating pharmacological agent. And that's great. Sometimes people are braced, and the bracing does well because it decreases the amount that they're pronating and can take some of the stress and strain off the peripheral nerve. In this area where you see injection, I would caution against steroid injections. For some reason, we have a lot of people that are injecting the tarsal tunnel with steroids, and we've sadly seen some iatrogenic cases of nerve injection injuries that are really quite difficult to take care of. So a steroid is really never to be injected in the tarsal tunnel. It's different in the carpal tunnel, and the hand surgeons will say, yeah, well, we use steroids all the time for the carpal tunnel. Well, and the answer is, well, you got, I think 9 tendons with synovial sheaths in that area. So it's different. It's a different anatomy a little bit, what you're dealing with. But if you inject intrafascicularly into a nerve with a steroid, except dexamethasone, you're going to have irreversible fascicular damage. So you have to be really cautious if you use steroids. We never use steroids. Now, what we are using more and more is glucopuncture and hydrodissection with D5W. This is becoming very beneficial to us because it is it's about as benign of a treatment as you can get. And we've seen some pretty great successes with it. Tarsal tunnel is probably one of the more difficult areas just because of all of the dynamic things that are going on that we talked about. But still, I think because of the fact that glucopuncture or hydrodissection with D5W is so benign and the chances of making a patient worse are really small if you know what you're doing and you know how to ultrasound. But why not give the patient a chance? Because that can make them, asymptomatic or, actually can live with their condition quite well. Now, if you get into surgical management, we're going to talk about the actual surgery that we do for tarsal tunnel. But basically, you can talk about surgery for tarsal tunnel as either tarsal tunnel surgery itself or extra-tarsal tunnel, meaning that we're doing something away from the tarsal tunnel.
And now, a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation, That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
Extra-tarsal tunnel procedures would be such as the proximal nerve decompressions that I already talked about, because you're not operating in the tarsal tunnel itself. A lot of times, where they do have a definite proximal tibial nerve compression, it's kind of a double crush syndrome. I know you all are very familiar with Upton and McComas's work where they talk about the double crush syndrome. I think they published it back like 1973 or something like that. But anyhow, if you remove sometimes one site of the double crush syndrome, then the other site can function quite well. The center one here where we talk about subtalar joint arthroesis gastroc recession, basically what we do here is we put a little plug between the talus and the calcaneus that keeps them in a more neutral forefoot to rear foot position, and that decreases the tension, it decreases the tension on the posterior tibial nerve, but it also decreases the intratunnel pressures. So we're able to do quite a bit sometimes with that. Now, why did I put a slide in here about carpal tunnel? And the reason I put a slide in here about carpal tunnel is that it's in the U.S., in the United States population, it's about 2%. But in our diabetic population, it ranges from 14 to 28%. So this gives you an idea of how a metabolic condition can greatly increase the odds of someone developing a nerve compression. And I would say from an incidence standpoint, clearly tarsal tunnel isn't 2% of the population, but it's much higher than a lot of people would think. Now, there's one other thing that I really think is important about carpal tunnel syndrome, and that is that if a patient comes in with a complaint of tarsal tunnel and they are diabetic and they have had a successful carpal tunnel decompression, you can pretty much tell them 100% of the time that they will have a positive outcome from your surgery. And this was published by the Neurosurgery Department at University of Arizona in about 2005. But it's a very powerful predictor because in this subset of the population, if they had a successful carpal tunnel decompression, you can pretty much rest assured that they're going to have a very good outcome from a lower extremity nerve decompression. So that's kind of an interesting little side benefit there, something that you can plug back into your history of present illness and taking that little extra time with the patient. So what do we do for tarsal tunnel? Well, as I stated, it's really 4 tunnels that we have to take care of. And if you want to make it 3 tunnels and forget the medial calcaneal nerve, that'd probably keep you out of trouble 90% or more of the time. But we want and have to address what's going on in the portopetus with the medial plantar nerve and lateral plantar nerve tunnels. That's what's really critical here. So incision placement. It's amazing how fundamental this is, but how many patients I will see that have their incision in the wrong place. And so what we like to do is we want to be, posterior to the medial malleolus, and we lay out where the medial plantar nerve tunnel, lateral plantar nerve tunnel, and we're going to aim our incision right in this area, and that will give us good exposure to both the medial and lateral plantar nerve tunnels as well as the medial calcaneal nerves for this. Now, a lot of times I'll see the incision up here, and what this incision will do is basically allow the patient to have a decompression of their posterior tibial tendon, which doesn't help their nerve too much. I've actually had a patient that had 6 surgeries before we saw her on each side. So she had 12 tarsal tunnel surgeries. And I think the first 3 that she had, it was the situation where they were actually decompressing the posterior tibial tendon, which made no sense at all. If it's too posterior, they can get the lateral plantar nerve tunnel and the medial calcaneal, but they can't get the medial plantar nerve tunnel. So it's really important. Incision placement's critical, as with anything. Then we like to carry things down. Now, this is a great photo because it shows a couple of things. I haven't even cut the flexor retinaculum yet, but you can see that with my scissors, I can lift up on this. It's not usually an area of high compression. This tissue isn't usually very tight in the spot, and this correlates with what Dr. Iborra and Dr. Villanueva showed us with their intratunnel pressure measurements. So we want to come in here, and we always like to work proximal to distal in these situations. So now I've isolated the posterior tibial nerve or tibial nerve, and you have to be very careful when you loop the nerve, and you don't want to pull on it too much. So we're pretty careful here. And now that we've identified the nerve, we're going to take it distally and see what's going on in the medial and lateral plantar nerve tunnels. And as we can see here, we've reflected the abductor hallucis muscle off. This is the deep fascia to the abductor hallucis, and I'm able to run one of these little elevators down the medial plantar nerve tunnel and one down the lateral plantar nerve tunnel. And that allows me to delineate those tunnels. And as we can see here, a little bit closer, notice the orientation. So this would be your lateral plantar nerve tunnel, and it's coming more as the lateral plantar nerve would cross the foot. Medial plantar nerve tunnel is more in the orientation of where you would expect your medial plantar nerve. So we've got the deep fascia of the abductor hallucis. A would be the medial plantar nerve tunnel, and B would be the lateral plantar nerve tunnel. This is a little bit closer up. So now what we're saying is here's our medial plantar tunnel, lateral plantar tunnel, and this is the septum between the 2 tunnels. And as Dellen pointed out, this septum, it's very important to take it out, or at the very least divide it so that it increases the decompression, or it decreases the tension in the whole area. And now we can see after we've started our decompression, I haven't taken out the septum just yet, but you can see how much more the lateral plantar nerve tunnel has opened up. Once we're complete, we're able to run your finger down into the plantar arch of the foot. And this is really what you need to make sure that your decompression is adequate. And so you can see that if we were just up in here decompressing it, you would miss everything that's going on and where the sites of real nerve compression are. Now, one of the things to pay attention to in this picture is look at the vasa nivorum. It's already starting to fill up on this nerve after its decompression. As we continue the decompression distally, if we monitor this, you'll see more vascular perfusion in the nerve itself. That's a very positive sign. And then we close it up. We like staple closures for this for several reasons. Two that come to mind right off the top is one, it allows, if you're going to have some bleeding in this area, it allows for extravasation of that blood so you don't end up with a postoperative hematoma. And the other thing is that the staples provide some negative feedback. If the patient tries to put too much weight or too active, the staples will pull on them and kind of slow them down a little bit. So that's kind of how we do our traditional tarsal tunnel surgery. But about 12 years ago, well, maybe more than that, actually, I can't remember, we started a minimally invasive technique, sometimes endoscopically assisted. And this patient had tarsal tunnel syndrome in both feet. This was the first foot that we did. This was the second foot. And you can see at 1 week post-op versus 4 weeks post-op. And in a non-minimally invasive technique, we usually stage these 3-4 months apart. In this situation, because the healing is so fast, with the minimal invasive nature of the technique, we're able to allow them weight bear more quickly. And so that allowed us to go ahead and intervene in the second foot a little quicker than what you would see. And at closure, this is the closure of our minimally invasive versus the maximally invasive technique. And our initial findings, we did actually pretty good, really good, actually. But you can see that if you look at things, we're much better in pain than we are in restoration of sensation. And that is true for almost any nerve decompression that we do in the lower extremity. We can get restoration of sensation about 70 to 80% of the time in tarsal tunnel, but we get pain reduction in a much higher percentage of that in the same patient. So if a patient says, well, I'm still numb, the question to ask is, are you still painful? And if they say no, then that's a success. Sometimes you just can't get the restoration of sensation like you ideally hope for. So post-op pain, you can see in this subset, we went pretty high on the pain scale to pretty manageable. I mean, people with this condition, you usually lower them 3 or 4 points on the pain scale. They're pretty happy, and it allows them to return to a functional life. So to wrap up the section on tarsal tunnel, it is a very demanding procedure, especially if it's done minimally invasive. We do it under microsurgical technique with loops. It really needs to be thought about from a global understanding. I mean, if you're doing a tarsal tunnel decompression, like I said, on somebody that has a gross orthopedic abnormality, you have to ask yourself, why? What am I doing here? Because I'm not going to make this patient any better. You're just going to make them worse because you're not taking care of the problem that started the whole thing off to begin with. And then release the real sites of entrapment. I can't tell you how many times I have done revision surgeries where we come in and it's completely virgin anatomy where the medial plantar nerve is or the lateral plantar nerve. And the patient just never had these decompressed. So now I'd like to talk about something that I'm very excited about. And we called this the Phoenix sign because the Phoenix, as you all know, is this mythical bird that was presumed dead. And then something stimulated it and it came back to life and rose from the ashes. And this is kind of what we saw in 2017. This is Rosaline. And her history was very interesting. She had a complete drop foot for 5 years prior to seeing us. And I wanted to see if, and her complaint was not that she couldn't dorsiflex her foot. At this time, her complaint was, I'm in tremendous pain. So in these situations, before we'll recommend a nerve decompression surgery, we always like to put a little bit of lidocaine on the nerve, see if that helps their pain. And so I had my nerve fellow, Dr. Nasir, who's actually now in practice in Jeddah, in Saudi Arabia. I had him give a block to see if we could relieve Rosaline's pain. And he came in right away and he said, you're not going to believe this, but she has full dorsiflexion. She can move her foot up and down. I said, no, that's not possible. So I went in and I looked at her and sure enough, she had complete dorsiflexion. So the initial response was, well, this is some kind of fluke or something like that. So I asked her if she would come back the following week, and I wanted to reproduce the block because I wanted to see it myself. And so I did, and I only infiltrated about 0.3 of a cc of lidocaine, and we'll talk about this, why it's such a small amount. And sure enough, she got complete dorsiflexion, 5 out of 5 motor strength, and she had 0 out of 5. It was absolutely incredible. So my thought process is what's going on here? And we thought that it might be due to the fact that most, all but one local anesthetic causes vasodilation. So if we have a focal nerve compression, we know that our vasculature is going to be impaired at that level. So let's talk about this a little bit. So the way we do this is we do it under ultrasound guidance. And you can see here's your fibular head out at the side of the leg, just below the knee. And then this is the deep fascia, the peroneus longus. And right here is the common fibular or common peroneal nerve. It's an extremely easy nerve to visualize, and it's a very easy nerve to put a small infiltration next to. So this was our observation, is that we were able to see increases in motor strength right after we gave a very small, a sub-anesthetic dose of lidocaine. And the question is why? Well, we'll talk about the physiology here in a second, but why is this so important? And the reason this is so important is because there are many, many patients out in the world right now that are living with a drop foot because it's presumed to have come from their low back, or it's presumed to have come from their multiple sclerosis or various other things. And it's sometimes very difficult for very adept clinicians, in fact, to separate what's causing my problem or what's causing my patient's problem. And so with this simple diagnostic test, there are going to be a lot of people that can have a very functional outcome because they're being diagnosed properly. And the second thing is that if they have a positive Phoenix sign, and I'll show you some of the details farther on down in this talk, but if we have this test and they show a positive response to this small infiltration of lidocaine, they have nearly a 100% chance of success at decompression. And that's a very powerful thing. We're now looking at this in other nerves, and in fact, we are seeing the same thing in the tarsal tunnel itself. So I want to just play this 3-minute video. I think it will show you not only the technique, but quite a bit, and then we'll come back in. Maybe.
We're going to demonstrate what we call the Phoenix sign. We're going to infiltrate a few tenths of a cc of lidocaine without epinephrine adjacent to the common fibular nerve. Before we do that, I'd like you, Jerry, to show us how much you can move the big toe.
As far as downward, I really can't bend it much, but coming backwards,
Okay.
I have no flexion coming up.
Hold it against my resistance. That's it, huh?
Yeah,
Okay. And your whole foot, hold it against my resistance. That's the best you can do.
yeah.
Okay. All right. So we're going to look at a couple of things after we infiltrate this. The Phoenix sign is a very diagnostic sign for peripheral nerve entrapment. And we will see what type of result we get after we infiltrate just about 0.2 of a cc of lidocaine. The first thing we need to do is identify the nerve, and it is just right there adjacent to the head of the fibula. All right, you feel just a little stick. Doing okay?
I'm fine.
Okay, we can see the needle coming in right there. We just get beneath the fascia to the fibularis longus, and you'll see us infiltrate right there. And we used 0.2 of a cc. We usually give this about 4 minutes to take effect, and then are able to test motor strength. Looks like you're starting to get a little movement now. You can pull your toe up now, pull your whole foot. You couldn't do that. Hold your big toe up. Pretty. Wiggle your
A
toe.
whole lot more strength in it and movement.
It's pretty
It actually
incredible,
bends
isn't it?
now.
Sometimes we also see an improvement in vascular perfusion right after this block with the ultrasound. We can take a look and see. So here's his dorsalis pedis artery, and you can see it's pretty prominent right now. You see that? Can you see that on the screen?
Yeah.
That's your artery now. That nerve block has made that artery more functional. So what that does is it confirms that you do have a local focal entrapment of this nerve at this spot, which is a known site of entrapment, just like a carpal tunnel in the hand. And by putting that little amount of lidocaine in on that nerve, that causes vasodilation. So more blood flow gets to that spot. When the nerve gets more blood, it's able to send a more powerful signal to the muscle, and therefore you can pull your big toe up. So it's virtually as close to 100% diagnostic as possible. It's about 90% predictive that you will, after nerve decompression, get better. So
Awesome.
So I think that, a couple of minutes shows an awful lot. This is just another little clinical illustration of a patient that came in with, a right common perineal nerve injury, and you can see that she's also demonstrating some color changes in her right foot. We gave her 0.3 of a cc of lidocaine, and in 4 minutes post block, you can see the change in her vascularity. So there's definitely some very autonomic things that are happening. following this block as well, which we're still in the process of investigating. So this was the first article that we published basically on the predictive capabilities of this nerve block as far as how it relates to nerve decompression. And as you can see, well, you'll see in just a minute, the slide's a little bit out of order. We think this is happening because of vasodilation. So as I mentioned before, there's only one anesthetic that I'm aware of that causes vasoconstriction, and that happens to be cocaine. And everything else causes vasodilation. And if you look at some of the other agents, you can see that marcaine or bupivacaine is even more vasodilatory than lidocaine. And we think that the reason this block works is because of increases in blood flow. And you can see this is an actual intraoperative photo of one of our common peroneal nerve decompressions. And you can see that within 6 minutes, there is no vasonavorum here. And then after decompression of where this nerve is entrapped, you can see vasonavorum starting to appear. And intraoperatively, we've actually done intraoperative EMGs. We see within 1 minute after decompression, restoration of normal motor function. And that's clearly, there's no placebo effect with that whatsoever, because it's just an electrodiagnostic test and the patient's completely asleep. So an increase in blood flow in a site of focal entrapment is a very positive thing. And that's what we believe is going on with the Phoenix sign. And to further our support in the vasodilation theory, we did a papaverin study. And so what we did is we compared, and this was a double-blinded, randomized prospective trial where we took 0.3 of a cc of lidocaine and 0.3 of a cc of papaverin. They got one or the other, and then they were measured for their motor strength. And we found that there was no difference, from the papaverin group to the lidocaine group. So it is not an anesthetic effect. It is something other than an anesthetic effect, because we know papaverin doesn't have any anesthetic capabilities. And most likely it is a vasodilatation effect from the sub-anesthetic dose of the lidocaine. Now, this is, in my mind, one of the most incredible, easy, translatable things that there could possibly be as far as helping people, because lidocaine is pretty inexpensive, and so is diagnostic ultrasound now. And so these tests can be done very easily with a very minimal amount of training. So that's what I have for the Phoenix sign. And there's a picture of the book that we're going to be giving out later. And I guess, so that leads me to, if there's any question and answers, I don't know, Miriam, if you want to do something else now. That's pretty much all I have.
It's so much what you presented. It's so much. We have, of course, questions that I am going to ask now. Thanks, first of all, Doctor, for amazing presentation. Let's start with questions.
No.
Dr. Islam?
Maria.
Yes. Okay.
First, I will ask a question. Professor Barrett, can you please turn off, stop your screen sharing? Thank you. Now, I will paste the link of the question. I paste the question in the chat part, into the chat part, and you can see the link and click on the link, and then you can answer the question.
Okay, so the first question was about the precise site of incision of tarsal tunnel surgery at what distance from the medial malleolus? So that's a great question. One of the complications of tarsal tunnel surgery is a painful scar. And if you look at the anatomy, there is a posterior branch off of the saphenous nerve that will come down posterior to the medial malleolus. And so we want to keep that incision 1.5 centimeters, maybe even a little bit more posterior to the malleolus, because we don't want that little sensory nerve branch coming off the saphenous to get cut. And the most important thing is to remember that if we are trying to get to the medial plantar nerve tunnel and the lateral plantar nerve tunnel, we want to make sure that our incision is right in between those so that we can access all of these tunnels. I hope that answers the question. The next question is there any relationship between obesity and tarsal tunnel syndrome? And the answer is without a doubt. And it's very simple to understand why a high BMI would increase the likelihood of someone developing a tarsal tunnel syndrome. One is that in overweight folks, they tend to pronate a little bit more. And so the pronation in and of itself is going to increase the strain on that nerve just from a biomechanical standpoint. The second thing is that most obese patients have some impairment of metabolic, or they have a metabolic syndrome or some impairment of their glucose or carbohydrate metabolism. And we know without a doubt that prediabetes and type 2 diabetes itself causes intraneural edema of the nerve. So that's already there. The other thing that a lot of times we forget is that patients with metabolic complications will, particularly type 2 diabetes, have deposition of AGEs in their tunnels, in their connective tissues that are the constituent tissues of that tunnel. So if your AGEs go up in that, your ligamentous tissue increases in thickness and also decreases in any elasticity. So that's a good question. So I think that ties it in between obesity. And then the other thing is the question is neuroinflammation higher in an obese patient or a non-obese patient? And I think you could make the argument that there's going to always be a higher level of systemic inflammation and neuroinflammation in somebody who is not optimized ideally from a metabolic standpoint. The next question is, what is the value of local steroid injection in tarsal tunnel syndrome? And the only value that I can think of is that it increases our patient load because people get iatrogenic nerve injuries, which is a very sad event. It doesn't do anything. I mean, other than the potential to damage the nerve with the steroid itself, what's it going to do? Calm it down for a week to 3 weeks or something like that? So I don't see any point in it whatsoever. I think if you want to inject it with D5W and put about 10 or 15 cc's in there, and you'll be surprised at your response with it. So those were the questions. Are there any other questions?
I have a question as well.
Yeah.
Can I?
Yeah, sure.
Okay, so I have a question. Which differential diagnosis do we have with the tarsal tunnel syndrome, which makes it a little bit difficult to diagnose patient with tarsal tunnel syndrome? And also we have such kind of what you mentioned, skepticism regarding that syndrome. Even some doctors doesn't think that this syndrome even exists. So which syndromes you are like trying to exclude when you are trying to diagnose tarsal tunnel?
It's a great question. So anytime someone comes in and they're complaining of feelings of tightness, constriction, burning sensations, loss of sensation, you have to then automatically default into, all right, this patient has a peripheral nerve entrapment. Then it's incumbent upon the practitioner to determine, well, where is the level of that entrapment and what's really causing that entrapment? And like we mentioned, there's a lot of orthopedic deformities that have to be looked at because that's putting the nerve into a position that it's already strained, has more stress, tension in it. So that's going to make it that much more likely. So those are the things. I don't know if I answered that as much as you wanted me to respond, but as far as differential diagnosis, I think the other thing is if there's any suspicion that there's a space occupying lesion, that's why your imaging is so important. And with ultrasound, it's super easy to get an ultrasound in the clinic. And within 5 minutes, you can tell whether or not there's a space occupying lesion.
Yeah, for example, I asked regarding lumbar radiculopathies and other radiculopathies caused by diabetes, maybe. And also, I asked regarding the fasciitis, what we have also here. So,
Yeah, so yeah, no, those are great questions because there are so many people that have this multiple etiology heel pain syndrome, which many times is tarsal tunnel syndrome. So there's no rule. I wish there was a rule because it would make all our jobs a lot simpler that patients could only have one thing causing their problem. Because if that was the case, then it'd be a lot easier to treat patients. But a lot of patients that will come in with tarsal tunnel syndrome have many of these factors. They have they are obese with a high BMI. They have type 2 diabetes, which makes the nerves swell. They have plantar fasciopathy, which changes the gait and the pressures in the tunnels themselves. So there are so many things that are going on. I didn't want to confuse anybody, but I wanted to bring the attention to that there's a lot of factors that we have to take into consideration with this in order to get it right for the patient.
Okay, thank you a lot. And another question here is Islam Hassan Al-Arabi is asking, for how long can the lidocaine injection in Phoenix sign manner can reverse the foot drop?
Between 4 and 10 minutes. Now, what's really interesting on this is that, and we're just now starting to look into the vascular changes, but we have seen numerous patients that we can't palpate a dorsalis pedis artery. They have no artery, and they have no artery on ultrasound. So with your color flow and your Doppler, you're not able to get anything. And then 4 minutes after the block, all of a sudden now this artery opens up. That might have some pretty huge implications for the vascular surgery departments as far as when they're doing endovascular procedures. Imagine if they're really trying to go distal with an endovascular procedure, and all of a sudden you can open up an artery that wasn't opened up. It's going to let them get down there. So it's kind of exciting stuff. I think, of all the things that I've played around with in my 3+ decades of this, I can't say I'm more excited by anything other than, this Phoenix sign.
Okay. Do we have any other questions or anyone wants to speak out?
Okay, maybe we must talk about the gift and the answers. No. If there is no any other question or comment. Mariam, let me share my screen for now. And let me, okay. And this one. We have 7. First of all, I want to read the question. Which factor listed below does not increase the intratunnel pressure in tarsal tunnel syndrome? Answer A, pronation of the foot in stance phase of gait. B, supination of the foot in stance phase of gait. C, maintenance of a neutral position of the forefoot to the rear foot. D, type 2 diabetes. E, plantar fasciitis. And we have 7 answers. Let's see. Okay. 1 from Egypt answers. 2 from Georgia. I think one of them is Mariam and the others is Madonna. 1 answer is from Sudan. 3 answers are from Turkey, and 1 answer is from Kazakhstan. And the answers are here: Ayman Dilay Kulaç, Ayhan Kanat, Selim Bozdağ, Madonna Akobatse, Mariam, Abu Bakr Şommo, İslam Hasan El Arabi. And these are, and let's see, the first answer comes from Ayman from Kazakhstan. And the answer is maintenance of a neutral position of the forefoot to the rear foot. I think it's true, Professor Barrett. Is that right?
That's true. That is right.
Yeah.
Yep.
And Ayman win the prize and win the gift. Ayman? Okay, I will stop my share. Ayman, are you here? Ayman? Okay. Okay, Ayman won the
Yes,
prize again.
good evening. Hello.
Ayman also is one of our moderators, like Mariam and Madonna. And
Good evening. Thank you for your presentation. It was very useful, especially in Kazakhstan. We don't have that much information how to help patients, but we have lots of patients indeed.
I bet.
Professor Barrett, can you show the book if you have the book now with you?
Yes. Yeah.
Okay. Oh, it's a very big book. And can you sign it right
Yes.
now? We-
Yeah,
going to-
I can sign it for sure.
Okay. For
I want to just mention real quickly, people always ask, what is the cover? And the cover, these are morphine receptor sites. And this is the one that's before being treated. So you can see it's a little bit more in pain. And this is the more relaxed face because the morphine has hit the receptor.
Okay.
Ayman, can you send your address for cargo to Professor Barrett?
Okay, thank you.
Okay, you will send your address, Ayman,
Okay.
Yes, if you send me your address,
to the
and-
Professor Barrett.
send me your address and we'll get you the book.
Thank you very much.
All right.
That's amazing.
Mariam also gave the right answer, I think, but is that true, Mariam?
No,
Oh, okay.
because in the slide it was mentioned also this neutral position and other compressions. So I thought it was neutral position also was like pathology.
But I think Madonna gave the right answer. Right, Madonna? You can turn on your microphone.
Yes, I was a little bit late,
Yeah.
but it was an absolute pleasure to join and to listen to the lecture. It was very insightful. Thank you, Professor, for sharing your experience and insights. It's truly invaluable. Thank you.
Welcome.
Madonna and Mariam are from Georgia.
And you are also working in Georgia, I guess, Professor Barrett.
Yes, I'm on night shift.
I think it's a different Georgia.
Yeah. You can visit our Georgia as well.
Yeah.
Okay, Professor, thank you so much. Well done.
Thank you.
Wonderful.
Thank you once again.
I hope you all have a
lecture.
great.
It was great to listen to you. Thank you. I want to thank
Thank you. Bye-bye.
everyone who joined us.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.